Hello and welcome to this highly anticipated session, I'm going to say, because there's been quite a lot of hype and build up to it on Twitter and social media, covering the Essential Pain Management Train the Trainer workshop. So I'm going to be co-presenting this with my colleague and good friend, Sharon Kittkatt. So I'll briefly introduce myself. My name is Martin Galligan. I'm a lecturer practitioner at the Royal Marsden, and I've been involved in pain management for quite a long time in various different roles, from specialist nurse to lead nurse, and now with more of a focus on education. Sharon, I'll let you introduce yourself. I probably wouldn't do you justice.
Oh, thanks, Martin. So my name's Sharon Kittkatt, and I had a long career in pain management and introduced EPM in the last trust that I worked in. And I'm currently working at King's in London in nurse prescribing.
Perfect. So over the next sort of, we'll say 25-30 minutes, we're going to give you a nice overview and introduction to the Essential Pain Management package. So we'll have a little look around the background to what it is, how it started, where it's grown from, and what the main principles are behind it. And then we'll go into a little bit more specifics on how you might apply this to your practice, how you could run it, and then we'll run through some case scenarios with you as well about how you may be able to build these into your sessions in practice. So essentially, Essential Pain Management's been around for quite a while now, and its ambition is quite simple really, and that is to facilitate and standardise pain education, and to make sure that there's a nice sort of equal boundary across all professional groups, that we're all singing from the same hymn sheet really. And it's really a tool to improve quality and reduce variability in how we're teaching pain education across a variety of settings, both nationally here in the UK, but also internationally as well. So it's quite a big ambition, but quite a simple message as well. So if we look at pain management and compare it to something like trauma care. So trauma care is it's very well organized. So it's got multiple causes, much like pain. It's very much a team management approach, as we do in pain management as well. However, the difference we can see is how we tackle it. So when we tackle a trauma situation, it's very succinct and it's very prescriptive. So we always follow the ABCDE approach, and the way in which training is delivered follows that very rigid structure as well. So we always know that we've got our BLS training, our ALS training, and everybody knows what they should be doing when they should be doing it. So it's all very slick. And what EPM tries to do is it tries to bring a bit of structure similarly to what we do in trauma. So instead of an ABC, we introduce the RAT system, or the RAT system. And then instead of having ALS and BLS training, we've got the Essential Pain Management training. And that's the ethos of this. That's the ambition, is to have this RAT system embedded into practice. So when did it all start? So like I said, it's been around for about just over 10 years now. So it started back in 2010, and it grew out of the Australia and New Zealand College of Anaesthetists. And they developed the package initially. And they did the first sort of courses were run around Papua New Guinea. And then from there, it started to grow and develop, and there were working groups and courses being delivered across Africa. And from there, it's built up a bit more. And then it came over to the UK in 2014, where the first pilot was carried out in Bristol and some of the medical schools as well. And since then, it's grown massively, really. So not only in the UK, but also internationally. And although it started very much focused at medical students, it's now grown across the multi-professional groups as well. So we can see this is just a quick snapshot of the global picture of EPM. So in February last year, it was being run in just over 55 countries across the globe. So the ambition of standardizing pain education is one that's very attainable, and that message is spreading far and wide, which is quite exciting, really. If we look inward and we look at more of a UK picture, so the UK EPM team is led by Dr. Helen Mackins, who is the clinical lead, and she also works alongside with Dr. Anwar as well, who's the deputy clinical lead. And they sort of lead on the coordinating of the delivery of all these courses. It's quite difficult to put an exact figure on how many EPM courses have been delivered without the UK. However, we can say that it's been delivered across the vast majority of medical schools now, with some really exciting work in the pipeline around e-learning modules, especially aimed at medical students and junior doctors, but also some really exciting work doing cross-professional teaching as well, which myself and Sharon have been involved with. So it's quite an exciting time in the UK for EPM, so it's spreading across the UK. If you're in a part of the UK, you'll be pleased to know that each of the regions has a regional lead. So wherever you are in the UK, you will have a contact for support as well. And you can find all of this on the EPM website. So there's always somebody out there who's able to give you advice and support. So if you're not sure about it, or if you think you're the first person to run it in your region, it might be worthwhile just to contact your regional leads. And these are updated fairly regularly on the faculty website as well. So I'm going to hand you over to Sharon, who's going to take you through the RAT system.
Thank you. So as Martin said, the RAT system, the EPM system, is a very systematic way of managing pain. So we're using the term RAT, so it's recognise, assess and treat. And going back to that resus plan, it will be like the ABCDE system that you have for resus. So firstly, looking at recognise, does the patient have pain? Do other people know that the patient has pain? Which sounds really quite an obvious thing to say, but it's actually thinking about how people are actually recognising, are the whole team recognising, are carers recognising that the patient has pain? And this looks also, it goes into the definition of pain and the benefits of treating pain. So there's a wider capture of information there. Sorry, next slide, thank you. So the next stage is assess. So the A is for assess. So firstly, how severe is the pain? What is the pain score? And what is the effect of the pain on the patient? And then what type of pain is it? And this is really important. Have we got an acute or chronic pain? Is it cancer or non-cancer? Is it nociceptive or neuropathic? And of course, some patients will have both. And are there other factors? What are the physical factors? And what are the psychological factors of that pain? And then T is for treat. So firstly, the most important thing is to put the non-pharmacological aspect first. What non-pharmacological treatments can I use? Thinking of the importance of psychology, the pathophysiology, the mechanism of action of non-medication treatments. And there's a discussion around placebo that the group can actually have as well. And then it's looking at what pharmacological treatments can I use? Which medications to use, when and why? It looks at the limitations of the WHO ladder and the appropriate use of opioids and addiction. And this is particularly important now when we're looking at the opioid crisis, the guidance on prescribing opioids, and the effects of long-term opioid prescribing. So it's really important to actually think about that. So Martin and I, as Martin said, we've both been involved in introducing EPM, and I'm just going to talk to you a bit about my experience of how I introduced it, and then Martin's going to tell you about his experience, which is still ongoing. Of course, I'm not working in pain management at the moment, but still very much involved with this. So I started a few years ago, having listened to Helen Makin's talk about EPM at an acute pain conference. And it was one of those things when you're at a conference and you think, am I going to go back with all these new ideas and what's really going to work? But I looked at this and I had a bit of a light bulb moment, because I thought, well, hang on a minute, we are actually teaching different pain sessions for lots of different health professionals in our trust. So I went back to the team and said, what about if we think about introducing EPM? We've been teaching the same thing for years in different hospitals and people were just not getting it. So we thought, well, let's look at whether we introduce EPM. And we looked at the short half-day session, which we'll talk to you a bit more about in a moment. But we looked at the shorter session. We introduced it for nurses, but we invited other health professionals to come along. So we had some physios, occupational therapists as well. And we got really good feedback on this first session we did of the EPM. So what do I think the best bits are? It's really easy to teach. It's clear and it's concise. As Martin has said, it gives you a really clear framework and a systematic way of teaching about pain. Staff are so used to the ABCDE that they do like to have a systematic RAT system for pain. It encourages discussion and group engagement, and it covers everything at an appropriate level. It's all done for you. The slides you will see are all there for you to use. You can adapt them if you like. You can take some out. You can really play around with some of the slides. So you don't need to change anything if you don't want to. But if you do adapt it and add your own slides, a word of caution: don't overload and go back to what you were doing before by mistake. There are challenges, of course. Some of the medicine messages in particular will differ according to where you work and your practice in your trust. And for an inpatient setting, if you work in an inpatient service with acute pain, with PCA, epidurals, etc., you will have to ensure you've got other ways of ensuring that education takes place. And of course, now we've become really good at the virtual teaching, so that's a really good way of delivering that kind of information. So I'm now going to hand over to Martin. He's going to tell you about his experiences of introducing EPM.
Thank you, Sharon. My experiences are very similar to yours, actually. So I first came across EPM when I was at an acute pain conference. And it was almost like that light bulb moment where it was in my previous role when I was having lots and lots of requests for lots of different types of pain education from different healthcare professionals. And it was just becoming a bit too much to manage. So we made the decision to start to run EPM. So it meant that we could open up the study days to everybody, and we could deliver that same message across all professional groups. And it was actually really well received. So it was really reassuring to see that we were able to have study days that had nurses, physios, dietitians, we had the odd psychologists, we had quite a lot of podiatrists, and all coming together to learn about pain using the RET framework. And it was nice to see the multi-professional groups complementing each other and bringing different things to the mix as well. And so for me, it was almost, in a way, it made not only my life much easier because I was able to deliver one session for everybody, but it really enriched the sessions for people that were there as well. And it gave people a different insight into what was going on in different areas and how they could impact on their practice. And the thing that I started to see on the wards were people actually starting to use the RET system in their documentation. So whenever they were handing over to us or referring to the acute pain team, they were sometimes using the RAT structure to structure their notes, which was fantastic, really. So that was a real win. And I think the one thing I want to pick on what Sharon said was when you do get access to the slide set, there is a lot of slides. There's about 120 slides, if not more. And I would say that make it your own. I will admit that the first time I did run it, I did stick to the slide set, and it was really difficult to power through 120 slides. But once you adapt it to your needs to fit your service, it's so much easier and it's so much more flexible to use the system as you want to use it. So I think we're starting to hopefully convince you and get you around to the EPM mindset.
I think, Martin, going back to that, I think it's really interesting you were saying about the different skills that people bring and the different health professionals joining together, because everyone brings something different and has a different slant on how they would like to learn about pain. And also I think about the documentation, that's really important. And we found the same, actually, that people were starting, because they were so used to writing their notes in the ABCDE, they started to do this for pain referrals, and we were starting to write it in our notes when we were actually documenting an assessment, and that was really, really good as well. So it worked both ways for us.
It can be quite a powerful tool, really, can't it?
Yeah, absolutely. So looking at the course materials, there's lots. On the website, there's the manuals are there, the student manual, the instructor manual, and they're really, really detailed, and they're really good. You can print them off, you can use them to write your notes when you're doing your teaching, that kind of thing. If you're like me, you probably like to have something like that. There, of course, as Martin said, there is the very, very long slide set, and I adapted mine as well. And I didn't end up with as many as that, but you still do end up with quite a few. And there's the certificates that you can adapt as well, and everyone likes a certificate, so you can actually do those as well. And it's very, very adaptable, and everything's electronic, it's all there for you. So there's, if you contact the Faculty of Pain Medicine, there are MCQs with the answers, there's evaluation spreadsheet, and there's lots of help if needed, and we'll give you the details at the end of how to contact the faculty. And there is a great app that you can have on your iPhone. There is an EPM app that you can actually start to use to help you assess a patient. Really, really useful tool as well. Everyone likes to put something on their phone, and that will go down well with quite a lot of people.
Yeah, I really like the app because it's got the student workbook on the app, so you don't have to print out the workbook, and you can save a tree at the same time.
Brilliant. And then there's the endorsements. It is endorsed by the British Pain Society, Pre-Reg Pain Education. This is a practical guide to incorporating pain education into pre-reg curricula in the UK. Royal College of Anaesthetists, and the BMA prescribing guidance, so the safer prescribing of analgesics, and there's the link for that there. So it is endorsed very widely into teaching about pain. So I think Martin's going to take you through, as he is currently still running the course, so he's going to take you through how he does that.
So I think there's lots of different ways in which you can run the course. And I think the beauty of EPM is that it's really over to you, and you make it whatever you want it to be and to fit your needs. As long as you're sticking within the RAT structure, everything else is pretty much up for grabs, really. So if you want to stay to the core guide and the core manual, it actually comes with a sample timetable. So this is for a half day, but you can stretch out to a full day as well if you wanted to. So it really depends on what you want to do for your needs, really. So in my last role, when I worked in the acute pain team, we ran this as half days. So we ran it as a morning session, and we had these nice, short, sharp sessions of about 20 minutes, half an hour, with lots and lots and lots of group work and engagement. And that worked really well. Now in my current role as a lecturer, so I tend to teach across a lot of different modules, and with a focus on advanced practice, but also symptom management. So whenever I'm doing any symptom management teaching, I'll always sneak in the RAT structure to wherever what I'm doing. And what I found really helpful sometimes is even just to use the letters R, A, and T. So I sometimes stick them in the bottom corner of the slides that relate to each aspect of it. And then that way, when the students are looking back, they can see which aspects we're talking about and how it relates back to the structure. So you can fit this into anything you're doing, really. So if you've already got things prepared, just fit the structure around it, because it will probably already fit that preset structure that you have. So it's there for you, really. Now, obviously, that in normal circumstances, you would be doing face-to-face teaching. However, in the current climate, and why we're here this evening, is that everything's moved on to the virtual platform. And that shouldn't be a barrier to EPM. It is very much doable to do on the virtual platform. And there is a testimony on the faculty website, actually, of somebody who's recently run a virtual EPM module. So that's quite a nice guide to have a look at, just to see how they've done it in practice. So I just wanted to spend a little bit of time with you thinking about virtual learning, because I know this it is a hot topic at the minute, and it is an emotive topic as well. And I just want to break down some of the barriers for you. So it can seem very daunting, and it's very disconcerting to talk at a screen, especially if the screen doesn't talk back to you as well. So my tips and hints to you is to keep it really simple and use technology that you're familiar with. And there's lots of free technology out there. So this could be Microsoft Teams, this could be Zoom, could be Google Hangouts, anything you're comfortable and familiar with, you can create an online learning environment, really. I would say some really simple things that make sure you're in a nice quiet room. If you're having your camera on, or if you're asking the students to have cameras on, I would suggest that you set some ground rules of what is and isn't appropriate to be doing when you're on camera, or have things in the background. And also make sure that the sound levels are okay. So you've got an appropriate microphone, you're not in a very noisy environment. And as with any sort of teaching, that you're well prepared before you go live. As I say quite a lot, there's very little space to hide in a virtual classroom or in a virtual environment. So when it goes wrong, it can go wrong, but as long as you're prepared and you know what to do next, then you should be grand. So make sure all your slides are sorted, you're happy with screen sharing, and you've got a good format and platform for the day, and you should be grand, really. Sometimes it can be really difficult to keep the engagement going. So as I was saying, as we were both saying, that when we run these when we run the EPM in face-to-face environment, we used to do lots of group discussions and casework. And you can still do that in the virtual environment. You just have to be slightly more clever in how you do it and slightly more organized as well. So if you're using something like Teams or Microsoft or Zoom, you can have the option of having small breakout rooms or small group chats, and just trying to get everybody engaged in it as much as possible, really. It's sometimes really easy to sort of, if you can't see people, that attentions do tend to wander off. So just make sure that you're constantly touching base with them, asking questions, getting them to do some quizzes. There are lots of really fantastic free quiz platforms out there. So things like Poll Everywhere and Kahoot. They're fantastic resources that you can use that can really elevate an interactive session and make it really interactive with the students. So as Sharon said, all the information you can find is on the Faculty of Pain Medicine website under the EPM banner, and there's also a contact there for the administrator as well if you want to get some of the more niche documents around the evaluation forms and the MCQ questions. But all the slide sets, the manuals, everything else is freely available on the website. So I'm going to hand back over to Sharon to introduce some of the case studies.
Thank you, Martin. So just to also say a bit about what Martin was just talking about, I recently chaired a conference that was virtual, and some of the feedback we got was that the delegates really liked being in the group chat in the breakout rooms. They found it actually much easier to talk to each other than having to separate into actual rooms at a conference. They actually really quite enjoyed the breakout rooms. It worked very well. So I just wanted to say that because I know that it is the new platform, as Martin was saying. So, and also with the Faculty of Pain Medicine, they really do like to know what people are up to, and they're really keen to register, to keep a sort of a list of how many people are delivering EPM. So the details that Martin's just given you, it's really important that if people do start delivering EPM, do let them know, because they do like to know. Anyway, so on to the case studies. We thought we'd have a discussion between the two of us with two case studies, just to really go through about how to use the RAT system in more detail. So the first case study, a 32-year-old man caught his right hand in machinery at work. He presents with a compound fracture of his hand. So the question being to the group, if you had a group scenario, you'd be saying, how would you manage his pain using RAT? So of course, recognize. So we recognize he does have pain, and he's recognizing that he has pain. The assessment, how severe is the pain? Using a pain assessment tool, this man's going to have quite severe pain, I should imagine. Is it acute? Is it chronic? So it's acute pain. Is it nociceptive or is it neuropathic? Likely to be nociceptive. You could have a neuropathic element as well. Is it cancer or non-cancer? So it's a non-cancer pain. And what are the physical and psychological issues around with this injury? So you've got a man who's 32, he's caught his right hand in machinery. So the psychological issues around work, about using his right hand, is he right-handed? The stress about what's going to be the future, how bad is the injury, what's it going to be, what is going to be the outcome for this man? And then obviously the physical side of that as well, that he wouldn't be able to use that hand for a while. So treatment, looking at non-pharmacological, so looking at the support this man's, the discussion, the way the way the patient is approached, the way he's spoken to, the reassurance for him, and the non-pharmacological things you can do to actually support the fracture, making sure that there's the positioning, the comfort, keeping him warm, all the things that actually are comforting and compassionate about care. And then, of course, there is the pharmacological. Now, I don't know what Martin's thinking, but I would go straight in with if it was an A&E setting, with some IV opioid for this gentleman, and then thinking about the multimodal components of what you could continue on. So your simple regular analgesia, of paracetamol perhaps, and maybe a non-steroidal, but certainly going straight in with the WHO ladder, upside down, going straight in with a potent opioid to start off with that would work quickly. I don't know if Martin's got anything to add to that, so I'm sure he has.
No, I mean, I would agree. I mean, that sounds like a nasty injury, so I would go in with the good stuff to start with, get them nice and comfortable, and then work back down the ladder.
Yeah.
I think what I love most about these scenarios, so these scenarios are all available on the website as well, and they give you a real range of them. And on the surface, this looks like a relatively straightforward scenario, but you could make it as complex or as simple as you really wanted to. So as Sharon was saying about, he's a 32-year-old man, caught his hand in work. So what does that mean from the biopsychosocial model point of view? What impact is that going to have on his life? Is that he's going to be able to work? Has he got family support at home? How long is this going to be a complicated operation? How long is he going to be off work for? What's his support network around that? So you could really look at his risk factors for chronicity. You could look at his risk factors for sort of chronic opioid use. If this is going to be a long problem, is he going to need multiple operations? Is there a risk of long-term opioid use? What's the impact of that? So I think these are really flexible and they're really interesting case studies.
And it saves you doing your own. We did do some of our own before, didn't we, Martin? But actually these ones, they've worked them so that there is something for everybody almost in the list of case studies that they've actually put together.
Yeah, definitely. Great. Should we move on to the next one?
Yeah. So I'm going to let Martin do the thing, but I'll tell you about the patient. So a 55-year-old woman presents with a large breast tumor that has spread to her spine. She has severe pain. How would you manage her pain using RAT? Martin, do you want to do this one?
Yeah, I can do this. Is probably more my area, coming from a cancer background, really. So again, working through the system. So again, it's the recognition of pain. So recognize that this lady is in a hell of a lot of pain. And then when we're thinking about a cancer-related pain or a cancer population, it's sort of recognizing the implications of that pain as well. So what does that pain mean to her? So is this a new pain? And what's the connotations of that as well? So I have quite a lot of patients that would say to me that they see pain as a measure of disease, and if pain is worsening, then they see that as disease worsening, and then vice versa. So if pain's getting better, they see that as disease getting better. So what's the actual impact of this pain? And recognizing that can be really important. Assessment. So again, we're going to come on to the assessment of this. So we're going to want to use whichever assessment tool you're more comfortable with or you're more used to using in practice, whereas that's numerical rating scale, variable rating scale. If you want to be fancy, you can use something a little bit more in depth, like a brief pain inventory or something. And then again, it's kind of picking up on that holistic assessment as well. So not just focusing on the fact that pain has gotten worse, but what does the pain mean and what's the impact on her as a holistic being, and what's going to happen long term with this. And then moving on to treatment. So how are we going to manage this? So again, this is an interesting one. So I would probably go in with an opioid as well, but I would want to look at sort of the wider pharm and non-pharm options as well. So looking at things like heat and cold therapy, perhaps looking at some additional cancer treatments as well. So maybe some bisphosphonates. Could you have some more radiotherapy, chemotherapy to treat the bone disease itself? And then again, bringing in all your other aspects as well. So not just the opioid, but considering, is this nociceptive? Is it neuropathic? Is it acute? Is it chronic? In this situation, it's probably a bit of everything, really. So you're going to have to bring in a real multimodal range of treatments for that one.
I'd agree, yeah. And I think also, as you said, this is a classic example of where there will be lots of different health professionals involved as well in this, with the management of her pain.
Yeah, definitely. So, I mean, you're going to want to get the oncologist on board. You want to get a bit of physio involvement as well, because, you know, we've got disease in the spine. So is that affecting mobility? You may want to get occupational therapy in as well. So it's, you know, it's a real team approach here for this one.
And it would be, and using the RAT, of course, if you are assessing a patient like this, or the patient in the first case study, is using that RAT, as we've said, to actually document your assessment. It makes it so much more logical, and you don't miss things out because you are working through a system yourself. I think when you're writing notes, when you see a patient with pain, it can be very easy to go write an essay and actually you can actually make it more succinct, I think. I don't know what you think, Martin. I think it's...
Yeah, no, definitely. And I think having that sort of really clear structure is really helpful for when you go and hand over to somebody else as well. Especially if you're looking at this from a pain team point of view, we're always going to be handing over to the parent team. And in order to hand it over in a really succinct way and make sure that you're communicating your plan over to them, the RAT method can be a really nice way of doing that.
Yeah, absolutely.
Great. Okay. I think we've come to a natural end.
So to summarize then, so using the RAT system, so we've said R is for recognize, so recognizing the patient has pain. They recognize they have pain. Who else recognizes? A is for assessment, severity, looking at whichever pain tool you might use, how you're going to measure, and how you're going to reassess. The type of pain, is it acute or chronic? Is it nociceptive or neuropathic? Is it cancer or non-cancer? So that gives you a really good start as to how you can then go on. And are there any other factors? But it also gives you a start to think, how am I going to treat, which is the T in the RAT. So non-pharmacological is really important, and the pharmacological. And then, of course, it's the most important thing is to reassess and go back to R and then A and then T.
Grand. Well, we have come to the end of our EPM introduction and overview, and I hope you found that useful and helpful, and I hope that we've inspired you to take EPM into your areas. I just want to say thank you to the NAPS committee for inviting us back to do this session, and thank you to Sharon for doing the session with me.
No, thank you very much, Martin. It actually makes me think, oh, I wish I was doing this again at the moment. So because it reminds you, it's reminded me certainly of how great it is and how it actually really does work. It genuinely is a really good way to teach about pain, and it is so straightforward. So thanks, Martin, as well. It's really good to do the session with you.
No worries.
We'll be face to face for our workshop again in the future, hopefully.
Yes, you'll see us back together in face to face, hopefully in the not too distant future.
Thanks, everybody.
Thanks.